Hello out there, everybody in medical education land. Conrad Fisher greets you again at the beginning of our exploration of the bowels. I send you all of my best wishes, all of my goodwill through this invisible method of videotape wherever you happen to be in the world. Let us once again recommit ourselves with intensity and passion to the study of this branch of medicine, remembering something that all that you are working for, all that you are sacrificing for, all that you are making efforts for, you will achieve. You will achieve your goals, and you will help people and help yourself. Let us begin with gastroenterology again today. And I am delighted to be with you here today as we discuss something that's always been very important to me, difficulty swallowing. Therefore, dysphagia. All of the things that present with dysphagia or difficulty swallowing. Dys means difficulty, not necessarily pain on swallowing. Pain on swallowing is from the Greek word odinos, for pain, odinophagia. But dysphagia is simply difficulty swallowing, and difficulty swallowing implies that the food or the liquids get stuck in the chest as they are going down. Therefore, when all the patients have these things, they will all experience weight loss. No matter what the etiology is, they will all have weight loss. So dysphagia in general will have weight loss associated with it, so we don't have to say that over and over again for each particular type of dysphagia. They will all have weight loss because you won't gain weight when you cannot swallow. You won't gain weight when it is difficult to swallow. Therefore, dysphagia also, in general, for those of you I know who want to have all the level of intelligence and knowledge of a dorsal root ganglion and say, oh, please, Dr. Fisher, please, I don't want to have to learn too much detail because I didn't get enough oxygen at birth and I only want to learn 2 points. Dysphagia, difficulty swallowing, weight loss, barium study as the initial test, endoscopy is the most accurate test, barium study is the initial test, or manometry as the most accurate test. Therefore, no matter what the etiology is. So how would I tell that you are without the ability to relax? Kalos, without the ability to relax your lower esophageal sphincter. Why, gee, that gives dysphagia or difficulty swallowing. Well, so does cancer. That also gives dysphagia or difficulty swallowing. So how would you distinguish them? Remember our original process. The questions give you history, physical, maybe some labs, maybe not some labs. History, physical, maybe labs, maybe not some labs. And then it asks the questions, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? Therefore, in answering the question, which of the following is the most likely diagnosis? When would you say achalasia? Which of the following is the most likely diagnosis? Why would you say cancer? Which of the following is the most likely diagnosis? Why would you say scleroderma? For instance, what will be different in the history and physical to be able to answer each of these? A, achalasia, B, cancer, C, scleroderma. What will be different about each of these things different from diffuse esophageal spasm? Diffuse esophageal spasm of, oh yeah, I swallowed a nutcracker. I got a nutcracker esophagus. I got a nutcracker esophagus. Why would you answer that as the question, which of the following is the most likely diagnosis? We are never far from these original questions. We meditate on them. We contemplate them, and all of our studying is with these original questions. Which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? And your favorite and mine, the most common stem, what would you do next in the management of this patient? Now, when it says do, does do mean a test or a treatment? Speak louder. Get closer to that video monitor. I can't hear you. Do next could be either a test or a treatment. What? You mean they're going to ask me to choose the difference between tests and treatments? That's the whole point. The whole point is to say, hey, does this guy taking step 2, does he know when you should get a test? Does he know when you should get a treatment? That's the whole point of the test. The whole point of the test. You ready? Conrad Fisher will now tell you the entire point. It's not that you have not heard of the tests and the treatments. It's not like you never heard of an esophagectomy. It's not like you never heard of a barium esophagram and manometry. It's not like you never heard of calcium blockers and nitrates. I feel like the weather girl here sometimes. There's actually nothing on this board. I'm just pointing to things. It's not like you never heard of calcium blockers and nitrates. The question is not whether you have heard of the tests and treatments. You ready? The main thing for both step 2 and step 3 is the order in which to do things. That is what the answer is. What comes first? What comes next? What is the order? Timing. What is the order in which to do things? That is why you have come to see me. Now, I can't seem to see you, but you have come to see me to learn the order in which to do things. That's what the book can't tell you precisely. In this circumstance, what would you do next? In this circumstance, what is the most appropriate action? In this circumstance, what is the next best step in management? Test or treatment next. Test or treatment next. What is the order in which to do things? Now, the difference between all of these, how would you answer the question, which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? Is you can't base it on difficulty. You can't base it on weight loss. You can't base it on those things. So what would be in the history and physical to say achalasia? Well, achalasia is going to tend to be in the younger person. Cancer is in the older person. Yeah, achalasia tends to be in, the question will say, the younger, non-smoker, non-drinker. Esophageal cancer will be in the older smoker and drinker. Now you might say, oh, Conrad, can't you smoke and drink and get achalasia too? You can. However, the questions are not saying the diagnosis is. The questions are saying which of the following is the most likely. So is it possible to have achalasia in a smoker and drinker? Sure. Is it possible to have cancer in a non-smoker? Sure. It's just not the most likely. It's playing the odds. Older smoker, drinker, younger non-smoker, non-drinker, because tobacco and alcohol are multiplicative. And remember, on step 2 or step 3 or any step you got, when the question says, which of the following is the most likely to result in immediate improvement in mortality, in survival? If stopping smoking is in the answer, say stopping smoking. Coronary artery disease, which of the following is most likely to result in immediate improvement in survival? Stopping smoking. Stopping your having lipids, stopping having a family history, stopping hypertension, fixing your diabetes. You are so smart. Can you say stop smoking? I thought you could. That's very good. Look at that. I can remember 3 objects at 5 minutes. Which of the following is most likely to result in immediate improvement in outcome? Which of the following is most likely to increase survival and decrease the risk of all-cause mortality? The average life expectancy for a man in the United States is about 77 or 78. The average life expectancy for a woman is about 79. Most men die before their wives. Why? Because they want to. Now, why is it that you can, the fastest way to raise survival, if everyone stopped smoking, the average for both the man and the woman would rise on average by 3 to 4 years. In other words, if all cigarettes disappeared from the United States tomorrow, the average life expectancy would be 81 or 82 for women and 79 or 80 for men. It would go up 3 to 4 years for both. Older smoker, drinker, multiplicative with alcohol. Now, what else is going to be different? Achalasia will give you dysphagia for both liquids and solids at the same time. Both liquids and solids at the same time. Am I over too far this way? Whereas the cancer will be first solids, then liquids. First solids, then liquids. And you say, how do you know that's true? I don't for sure until I have, the color-coded Dr. Fisher. History is in blue. Diagnosis is in green. Treatment is in red. How do I know for sure? Until I have the endoscopy. And the answer is, I don't know for sure. But you know what? I never saw a question that said, question 48. The diagnosis in this patient for sure is. The questions don't say the diagnosis for sure. The questions say, which of the following is the most likely? Not for sure. So even though it may not be for sure, it doesn't have to be for sure. It just has to be probability. There is an advantage to a board test. Now, I know you don't think that there's an advantage to a board test, but there is. The advantage to the board test is if they want you to know the answer, they have to tell you something. There's an advantage to a board test. Two things. One, if they want you to know that it's esophageal cancer, and they haven't said, the biopsy shows cancer, and they want you to know from history and physical, they'll have to tell you. It's an older smoker or drinker with dysphagia more for solids. Then over several months, the dysphagia progresses till eventually the patient has difficulty swallowing liquids as well. If they want you to know the answer, they have to tell you. Now, what's the second advantage of a board test? No matter how much pain you feel in your studying right now, this preparation is good. I hope it hurts as much as possible. Why? Because that means you're intensively studying more. Walt Whitman says, who has gone far? For I would go farther. Who has been bold and true? For I would be the boldest and truest being of the universe. Who shall sing hymns fit for the earth? For I am mad with the devouring ecstasy to sing joyous hymns fit for the whole earth. I hope it hurts because all this studying is good. And good for other people too. Okay? Don't edit that out. All right. Now, the diagnostic test for achalasia. A chest x-ray, if it's there, might show some widening of our mediastinum, okay? God didn't mean us to have an esophagus of 6 inches across of undigested bacon cheeseburgers or undigested chicken tandoori. We weren't meant to have an esophagus this wide, and it might be visible even if you're having sag paneer this wide in your esophagus. Gee, what'd you have for dinner last night? Well, I can still show you. It's right here. Now, what's the difference between that retained food from the achalasia that you can see on a chest x-ray, that you can see on a barium study, and the type of difficulty of retained food that you might see with something, say, such as a Zenker's? Now, there is a person who also has retained food. There is a person also who's regurgitating as well. There's also a person who, my favorite and yours, wakes up with undigested food particles on their pillow. Oh, that's attractive. Hi, what'd you have for dinner last night? Well, why should I describe it when I can show you? The difference between the Zankers and the achalasia is both of these people are storing up rotted food and making a compost heap inside their gastrointestinal tract. The difference is both of these people can regurgitate, but the difference between this regurgitator and this regurgitator is that this person is regurgitating one truly undigested. Okay, all right, you say, well, we're both regurgitating undigested. This person can express that food by pressing on the back of their own throat, press it out. The other thing is, Zankers is unique. I know you love it. It's the only time you woke up in the first 2 years of medical school. Zankers has someone who smells like a dog died in the back of their throat. It smells bad. Oh my God, have you been gargling with fermented donkey urine again? Zankers diverticulum. It's in there rotting like a compost heap in the back of your own throat. And that's the biggest difference here. These people don't smell so bad. Gee, you know, I'm always grateful for the things in our relationship that are advantages. Why? Because I used to date a guy who had Zankers, and you know, you both kind of regurgitate a lot, and both of you don't seem to appreciate my cooking because you're both storing it up and vomiting it up the next day. But you know, he smelled bad, and you smell kind of nice. These people smell okay, and these people smell evil. And that's the biggest difference. Then this person is able to voluntarily express the food particles by saying, gee, what'd you have for lunch? That's attractive. Time to have an internet relationship with this person. Now, achalasia, back to these, what's distinctive between these? What's distinctive? Achalasia is the person who can have a wide mediastinum on that chest x-ray. Barium studies for a person with achalasia. Here is the heart in the back of that chest. And the difference between this person and the others is that the barium study will show that the esophagus is all coming down tight to a point here. Then it bulges out, and it's like a bag in there. Now, to the poetic amongst you, that looks like it coming down to a little point to you and me. It's understandable. Ekalos, without relaxation of that distal esophagus. But for the poetic, for the radiologists, they said, you know what? That sort of looks to me like a bird. Yes, there he is. And now that to them looked like a bird's beak. And since I live in a happy universe, I have to imagine that the bird is smiling. A little bird smile there. So that's a bird's beak. Now they don't really have that there, but they do have it coming down so that to the people who saw this, it looked like the little bird's beak there. Now, which of the following is the single most accurate test? Which of the following is most likely to lead to a definite diagnosis? The answer is neither one of these. The most likely diagnosis is with manometry. So manometry is the single most accurate diagnostic test. Endoscopy will be in the answer. However, endoscopy will be wrong. Rewind the tape. Endoscopy will be in the answer, but endoscopy will be wrong. Rewind. Endoscopy will be in the answer, but endoscopy will be wrong. Wrong for esophageal disorders wrong? No, honey. Wrong just for achalasia. Because the interior lining, the lumen of the esophagus, looks normal. It is not a biopsy diagnosis. The reason that endoscopy must be done for cancer is that you must have a biopsy. You must have the biopsy because you need histology. Must have a biopsy, need the histology. We don't need any histology here. We just need to see whether we have a problem with relaxation of that lower esophageal sphincter. Now, pneumatic dilation is the therapy for esophageal problems with lack of relaxation, pneumatic dilation. And pneumatic dilation is the best initial therapy for the people who have achalasia. We put a tube down your throat and blow up a balloon, and it's similar in a way to angioplasty. You're doing angioplasty of your esophagus. You're putting down an endoscope, you're blowing up a balloon, you're dilating it, boop, and therefore we have the ability to dilate up that esophagus. Pneumatic dilation. Now, botulinum toxin, Botox, the same botulinum toxin that you would use for blepharospasm to relax it. Hey, matey. Yeah. Oh, yeah. How are you? I'm fine. Gee, you don't seem very happy to see me. Why aren't you smiling? I am smiling. Botox, which is the same thing that you'll use to relax blepharospasm. Botulinum toxin for blepharospasm, esophageal spasm, anal fissure. Botulinum toxin relaxes all of those things. However, the problem with botulinum toxin is that botulinum toxin has to have a repeated injection at 6 months in 50% of patients. The other thing is that you have to have everybody with a repeated injection by 2 years. 50% a repeated injection at 6 months. Everybody had a repeated injection at 2 years. Do you really want someone crawling down your lower esophagus to repeat the injection? Pneumatic dilation is effective in 85 to 90% of patients. Doesn't work or refused? Botulinum toxin. Which of the following is the single most effective? And the answer is myotomy. Tomy, myo. Cutting the muscle. The myotomy. Heller myotomy procedure results in a nearly transmural laceration of the lower esophageal sphincter. This prompts a marked decrease in lower esophageal sphincter pressure and allows the easy passage of food. The most common complication of the Heller myotomy is reflux disease. Reflux disease with a myotomy. Besides, who wants their sphincter cut? Ouch. Most accurate therapy here, pneumatic dilation, standard of care, refusing it or failing it, botulinum toxin, everything fails, myotomy. Esophageal cancer, the older smoker and drinker. First he can't swallow his meat. Meat gets stuck. Then he can't drink liquids either. Now, barium studies could be done, but the problem is that no matter what the barium shows, you need to do endoscopy anyway because it's a biopsy procedure. Therefore, the best initial therapy is surgery. Surgical removal. That is the only way to fix your esophageal cancer is a surgical removal. It's the only way to fix that esophageal cancer. In other words, there is no non-surgical curative therapy. No non-surgical curative therapy can't fix my esophageal cancer without cutting it out. Well, why should I answer a question with something like the CAT scan, the CT scan, computerized tomography? The answer is that computerized tomography will be in the answer, but it cannot be the most accurate test. Cannot be. Why can't a radiologic test be the most accurate? Because you cannot stain a CT. You can't get culture on an MRI. You can't get histology on a nuclear scan. The only way to diagnose something histologically is with a biopsy. Then why should I do a CT? CT scan is to tell the extent of your disease. Esophageal cancer is predominantly squamous cell carcinoma, particularly in the proximal 2/3 of the esophagus. The distal 1/3 of the esophagus can be adenocarcinoma, particularly in those patients who had Barrett's esophagus. Barrett's esophagus has a transformative potential of 0.4 to 0.8% per year transform into esophageal cancer. However, the most common as a single choice is still the squamous cell carcinoma overall. The squamous cell carcinoma, given the fact that the esophagus has no serosa, spreads circumferentially in a centripetal pattern around the esophagus, meaning it starts at the esophagus and spreads locally into the surrounding structures. Computerized tomography is obtained to determine the extent of disease. Localized disease is always resected surgically in an attempt to cure cure. Did you say cure? Sustained remission. In an attempt to provoke a sustained remission, the CT scan is done to determine, 1, can I cut this thing out of me? Is this spread around here? I got esophageal cancer? Oy! Can you cut this thing out of me? Well, I don't know. I could, but on the other hand, I wish I had a one-armed doctor. Why do you wish you had a one-armed doctor? Because my doctor was always saying, but on the other hand. So therefore, if you can cut it out, this computerized tomography or CT scan tells you if the disease is localized to the esophagus. If it is localized and not extending into the surrounding tissues, surgical resection is feasible. If it is spread into the surrounding tissues, you can only do palliative therapy. Palliative therapy basically means to ease your exit as we are shuffling off this mortal coil. And that is 5-fluorouracil and radiation. Palliation with radiation. Palliate to radiate, radiate to palliate. Radiation cures almost no form of cancer. Now, 100 years ago, actually 120 years ago, when Madame Curie, really Sklodowska, okay, when Madame Curie was discovering radium and the first radiotherapy, they didn't have chemotherapy at the time, at least before Paul Ehrlich develops all the first chemotherapies, so they thought we will radiate things to eradicate the cancer. Problem is, radiation also causes cancer, including the leukemia that Madame Curie died of herself. So the problem is radiation might shrink something, but it can only mop up cells. It cannot outright cure virtually any form of cancer, one of the only exceptions being stage 1 and occasionally stage 2 Hodgkin's disease. Stage 1 with no B symptoms might be able to be eradicated by radiation alone, but most things, radiation is palliative therapy, adjuvant, meaning something given in addition to the chemotherapy and the surgery. So when you say curative, with the exception of lymphoma and 1 or 2 other diseases, radiation is never curative. It is palliation in combination with chemotherapy, 5-fluorouracil. I have stomach cancer, 5-fluorouracil. Colon cancers, 5-fluorouracil. Stomach, esophagus, colon, stomach, esophagus, colon, stomach, esophagus, colon, stomach, esophagus, colon, 5-fluorouracil. 5-fluorouracil. Remember, when somebody tells you that you have gastrointestinal malignancy, always think FU. I have GI malignancy, 5FU. Therefore, that might not quite make the final cut. So therefore, 5-fluorouracil is not just for esophageal cancer, it is for all forms of GI malignancy. Surgery is the only way to cure the disease. Well, what's going to be different about scleroderma from the other things? How am I going to tell someone's got scleroderma versus someone just having, let's say, a Schatzki's ring or a web? Schatzki's ring or webs, rings or webs. Schatzki's ring or webs. What's going to be different about scleroderma? Well, the diagnosis of scleroderma esophagitis is similar to the diagnosis of diabetes-induced renal failure. Almost never do we biopsy a kidney for diabetes-induced renal failure because we figure, gee, guy's had diabetes for like 20 years and now his kidneys are not doing well. It must be the diabetes. It's unlikely to be that all of a sudden he got Berger's disease, Wegener's, polyarteritis nodosus, or he has another form of kidney disease with a history of diabetes and nothing else in the history. The same way it is implied. I have a person who has scleroderma and now they've developed symptoms of reflux. And boy, oh boy, have I never felt my gastric pH. A gastric pH of 1 to 2, the fires of hell are coming up into my esophagus. Remember that the concentration of protons between your gastric lumen and your blood is 4 million times greater, the acid content in your gastric lumen compared to your blood. That's what it is to go from a pH of 7.4 to a pH of 1. 4 million times more protons, 4 million times more acidic than your blood is the gastric contents. And it goes up into your esophagus like pouring battery acid into your esophagus. Now, achalasia is a lower esophageal sphincter that's tense and won't relax. Tense and nervous, can't relax. Whereas gastroesophageal reflux disease is a lower esophageal sphincter that's relaxed and won't contract. This is contracted, won't relax. Reflux disease is something that's relaxed and won't contract. And scleroderma just stays there and neither contracts nor relaxes. Scleroderma progressive, meaning gets worse. Systemic sclerosis, or scleroderma, is an esophagus that just stays there. Oh, I don't contract, I don't relax. And all the acid goes up into your esophagus. The treatment of reflux disease in scleroderma is the treatment of reflux. Proton pump inhibitors. And all you have to do is see a person with a history of scleroderma with profound symptoms of reflux as the burning goes up into the esophagus. Now, the one good thing about achalasia is you can never get reflux disease. How can the acid come out when you've got a lower esophageal sphincter? It's this small. You can't see it? This small. Well, the acid can't come out. Food can't go in, but the acid can't come out. The same thing with obstructive symptoms of cancer. Acid can't come out. The same things is with obstructions. The only good things about obstructions is acid can't come out. Well, what's different about diffuse esophageal spasm and nutcracker esophagus? What is different about diffuse esophageal spasm and nutcracker esophagus from the others? What's going to be different about these things? How are you going to answer? Which of the following is the most likely diagnosis? Spasm or nutcracker esophagus. The predominant complaint in this is pain. Pain. That's the big thing. Pain? No, difficulty. Difficulty. Well, what's the difference, difficulty or pain? Well, I don't know. I've had difficult relationships, but they're not painful. Okay, can have a lot of love in a difficult relationship, may not necessarily be painful. Okay, pain means ouch. It means that these people feel like they have just been punched in the chest. These people come in, they say, I think I'm having a heart attack. These people feel like somebody has just shot them in the chest. All of a sudden, I was just walking down the street, minding my own business, and all of a sudden, doing! I bet that was good for the microphone. Oh, oh man, does that hurt? Pain. Well, there is pain also associated with people who have esophagitis. How are you going to tell the difference between the people who have esophagitis? These people also have pain. What is different about their pain from the pain of the people? These have pain. These have pain. Esophageal spasm is on the differential for heart attacks, as you would call it, a myocardial infarction. These people looks like they have Prinzmetal's angina. Prinzmetal's angina comes and goes. Nobody knows Prinzmetal's angina. Sometimes I get it when I'm walking. Sometimes I'm at rest. Well, that's nutcracker esophagus. No, it's Prinzmetal's angina. Oh, gee, when I scope the person, when I do endoscopy, when I scope the person, the scope is normal. Gee, when I do angiography on a person with Prinzmetal's, the angiography is normal. Well, the usual medications like aspirin for Prinzmetal's is not effective. Well, usual medications like proton pump inhibitors and H2 blockers are not effective. The pain comes and goes. Nobody knows. It's like Prinzmetal's angina, but of your esophagus. Spasm. Well, what's the difference? This is pain too. The biggest difference is that the pain of esophagitis is only on swallowing. Only on swallowing. In other words, if you're not swallowing, this person does not have pain. If you're just sitting there minding your own business, you're not having pain. This person is only having pain on swallowing. Notice the itis part? That's because the lower esophagus is inflamed, pills, inflamed, pills, inflamed, pills, iron pills, potassium pills, iron pills, potassium pills, alendronate, risendronate, iron pills, potassium pills, alendronate, risendronate, iron pills, potassium pills, alendronate, risendronate, and tetracycline too. Not that anybody uses tetracycline anymore, but tetracycline, iron pills, vitamin C pills, potassium pills, alendronate, risendronate. Well, gee, how would you know it was alendronate and risendronate? Well, maybe it would be a person who's using alendronate and risendronate. That's smart. Pill esophagitis is pain on swallowing with a history of using the pills most commonly associated with esophagitis. Drink more water and sit up. It hurts when the pill lies there in your esophagus when you don't drink your pills while sitting up. It hurts when you have pills lying around your esophagus when you don't drink enough water. When you take your pills lying down, the pill lies there in your esophagus and touches it and inflames it. Doc, it hurts when those pills, alendronate, risendronate, and iron pills and potassium pills lying around in your esophagus, it hurts when those pills are in contact with that esophagus. So, gee, Doc, it hurts when I do that. Don't do that. Doc, it hurts when I have alendronate and risendronate lying down, not with enough water. Drink some more water. Sit up. Doctor, you're a savior. It's a miracle. I never thought of that. When I get alendronate, risendronate, iron pills, potassium pills, and I lie down and don't drink enough water, the pill lies there and inflames my esophagus. And you told me, drink more water and sit up. You're a genius. A super genius. Sit up and drink more water and get that pill off of my esophagus. But these people only have pain on swallowing. It is essentially like dyspareunia of your esophagus. It's irritated and inflamed, but only when something's rubbing on it does it hurt. No food going by, no rubbing. No rubbing, no pain. These people don't have to have something swallowing. This is intermittent, he says, hoping to spell it with an A-N-T or an E-N-T. I still can't remember. So intermittent pain. This is pain only on swallowing. Odinos, odinophagia. Okay, this, you could be swallowing, not swallowing, just like Prinzmetal's angina. Could be walking, not walking, can happen at any time. Well, Schatzki's ring and Plummer-Vinson, Schatzki's ring and Plummer-Vinson is intermittent. This is intermittent as well. Well, what's the difference? Intermittent difficulty, intermittent dysphagia, intermittent difficulty. This is intermittent pain. This is intermittent difficulty. Hey-ho! That's the whole diagnosis. Better be sure, because the scope looks normal here, and the scope is not really that useful here. Rings and webs are diagnosed with barium studies. They're diagnosed with barium studies because the mucosal surface of the esophagus is normal. The mucosal surface of the esophagus is normal. Barium studies will show the ring or the web bulging in. Here's the esophagus and but the endoscopy will show you a normal mucosal surface. Chest x-ray won't show you anything. Intermittent difficulty. Intermittent pain. Pain, yes, I know that I said that, but it's not the same. This one's only on swallowing. One, when I have a history of pills. Probably the single most common is a history of HIV with less than 200 T cells. I've got AIDS with a low CD4, definitely under 200, usually under 100. The only significant disease that occurs with a CD4 count less than 200 is pneumocystis pneumonia. Most of the others occur with a CD4 less than 100, if not a CD4 less than 50. A guy with AIDS comes to the hospital or the office with progressive difficulty and pain on swallowing, only on swallowing. It's an inflamed mucosa. If I'm not rubbing across a bacon cheeseburger across it, it doesn't hurt. Like dyspareunia of your esophagus. A guy comes with HIV, low T cell count, and progressive odynophagia and dysphagia. What would you do next in the management of this patient? What is the most appropriate action at this time? What is the next best step in management? What you want to do now? One of the only times, one of the only times that we're going to say the response to specific therapy is a method of making the diagnosis. One of the only times that we're going to say that the response to specific therapy is a way of making the diagnosis. One of the only times that we're going to say that the response to specific therapy, you give them fluconazole, and what else is fluconazole going to improve except esophagus candidiasis? If they're better, then you just continue. How long do you continue? Until one of two things happens. The HIV is cured, or the T cell count goes back above 200. You continue either lifelong or until the T cell count goes back up. All opportunistic infection treatments can be stopped if the T cell count goes up. All opportunistic infection treatment can be stopped if the T cells, they go up. You have pneumocystis prophylaxis, your T cells went to 300, stop the Bactrim. MAI prophylaxis at less than 50 T cells, your T cells went up above 100, stop the azithromycin. You had CMV retinitis, that sucks. However, if your T cells go back above 100, stop your oral ganciclovir, valganciclovir. Stop it. If you go back up in your T cells, you can stop the opportunistic infection medications. Why? Because 400 T cells by any means necessary is just as good as being HIV negative. Actually, anytime you go above 200, you'll be just fine. Your immune system will function essentially normally as long as those T cells go up, at least in terms of big things like esophageal candidiasis, pneumocystis, CMV, MAI, Mycobacterium avium intracellulare. Stop the prophylactic medications once the T cell count goes up. You continue the fluconazole lifelong or until the T cell count goes up. Now, what if the fluconazole has no benefit, no difference? It's the same. Hey, I put the guy on fluconazole and, 2 weeks later he feels the same way. He's still having pain. Well, I could go to barium, but that would be the most common wrong answer. Don't go to barium next. Barium may show you something. Barium will be abnormal. However, no matter what the barium shows, you're going to have to scope anyway, because barium, although it can show esophagitis, barium cannot sufficiently distinguish between esophagitis from herpes, CMV, esophageal cancer, aphthous ulcers, or various forms of esophagitis related to other infections. The barium study cannot distinguish because CMV, cytomegalovirus, HSV, herpes simplex virus, aphthous ulcers, Kaposi's sarcoma, or demonic possession needs endoscopy to make the distinction. Now you said, oh, but Daddy, you said that diagnostic tests would be in green and treatments would be in red. And that's because this is both diagnostic and therapeutic. Since candidiasis accounts for 90% of esophagitis and HIV, 1% herpes, 1% CMV, 1% Kaposi sarcoma, 1% aphthous stomatitis, since esophageal candidiasis accounts for 90% of the esophagitis in HIV, therefore fluconazole will be both diagnostic and therapeutic in 90% or more of cases. A guy comes to the office for progressive odynophagia. He's got HIV and he's got 23 lonely T cells. You put the man on fluconazole, and in the next 3 days he markedly improves and feels a heck of a lot better. You do not have to have oral candidiasis to have esophageal candidiasis. You do not have to have oral candidiasis to have esophageal candidiasis. And you don't have to have esophageal candidiasis just because it's oral. Thrush does not mean esophageal. Esophageal does not mean thrush. They can be there present together or separately often. You do not need to have, but I thought, well, why do you think I keep saying it? I know, but I thought you don't have to have oral candidiasis in order to have esophageal candidiasis. But stop that. No. Zip. Zip. Now, what is different about these? The scope, this is intermittent pain, this is intermittent dysphagia, difficulty, not pain, and this is pain but only on swallowing. Diffuse esophageal spasm and nutcracker esophagus. The most accurate test is manometry. Now, manometry tells us the pressure in that esophagus. Manometry. Hey, what's the best initial therapy for Prinzmetal's angina? Calcium channel blockers and nitrates. What's the best initial therapy for that diffuse esophageal spasm? Calcium channel blocker and nitrates. What's the best initial therapy for the spastic disorder? Calcium channel blockers and nitrates. Nifedipine, diltiazem, diltiazem, nifedipine, nifedipine, diltiazem, nifedipine, nitrates. Well, what? Gee, I think I said the same thing for looks like I said the same thing for both diseases. I kind of make it kind of looks like these diseases are the same. Diffuse esophageal spasm, nutcracker esophagus. I seem to have said the same thing for both diseases. Have I made a mistake before in my life? Why, yes, I have. One was experimenting with minoxidil. It didn't work, and nobody seemed to mind my balding anyway, except me. The other mistake is not here. The reason that they're both the same, looking like they're the same, the reason I said, how do you answer which of the following is the most likely diagnosis? What is the most accurate diagnostic test? What is the best initial therapy? The reason it looks like it's all the same is because they are the same. They're the same disease. What? What? How come in medical school they sounded like they were telling me about two different diseases? Oh, well, very easy, because if they want you not to learn it, they make it look like it's two diseases, so you have to learn twice as much. The only difference between these is the manometric pattern. The only difference between these is the pattern on manometry. If somebody wants you not to learn esophageal disorders, they start with manometric patterns, because then no one can understand it. You don't have to have the manometry. You can distinguish these by a distinct clinical pattern. The other thing is, isn't it strange when some people, some books, some things will give you manometry patterns first, when the manometry is obtained after you suspect the diagnosis? They're telling you to suspect the diagnosis after you have the manometry, but it's upside down. That's like saying, how do you know to buy the winning lottery ticket? Because I see the winning numbers. Well, how are you supposed to know it's the winning ticket until you scratch off the numbers? Oh, Mr. Zelda on Bleecker Street. How are you supposed to know to get the manometry? That's the whole point. Intermittent pain, manometry, calcium blockers, and nitrates. Schatzki's rings and Plummer-Vinson syndrome. Dilation, Schatzki's ring and Plummer-Vinson syndrome. Dilation, Plotsky's ring and Plummer-Vinson syndrome. Dilation like that pneumatic dilation? Yes, pneumatic dilation like that pneumatic dilation for achalasia. So therefore, Schatzki's ring and Plummer-Vinson syndrome. One little exception. Plummer-Vinson syndrome is associated with iron deficiency, and when you treat it with iron, some people get better just by treating with the iron. Some people get better just treating with the iron. Some people get better. Now, what's the difference? Treating with iron makes some people get better. But in general, Schatzki's rings and webs, ready? Rings and webs, dysphagia, sometimes intermittent. Barium studies dilate that ring and web. Doc, it hurts when I take that pill. Don't take that pill. Sit up and wash it down. Do what your mother told you. Esophageal candidiasis. Take fluconazole, and 2 days later, you're going to feel terrific. It's going to get better. It's a miracle. You're going to feel like a real doctor. You know why? Because people's lives are going to be miserable. They're going to come in. I can't swallow a thing. It hurts like crazy. I feel terrible. And in 48 hours, they're going to feel terrific, and they're going to think you're a hero. You're going to love this diagnosis. One of the most satisfying things. It's practically curative. Zenker's diverticulum. Usually little old ladies who have the back of their posterior pharyngeal constrictor muscles have gotten dilated up to the point where they have dysphagia and regurgitating undigested food particles. Boy, oh boy, close your mouth and breathe in the other direction, dumpster breath. Well, barium studies is the diagnostic test, but the most important thing for you, ding, 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 warning, warning, danger, danger, danger. The most important thing for you out there in step 2 land is not to assassinate your patients. The most important thing is, you ready? Do not scope. No scopes. No scopes. Warning. Now hear this. Now hear this. No scopes and no nasogastric tubes. No scopes and no tubes. No scopes and no tubes. You poke a hole out through the back of the Zenker's diverticulum. Let's do this endoscopy. Okay. Gee, what are you seeing? Do you see the esophagus? No, but I see the room behind them. What? Oh, bling! The problem with Zenker's diverticulum is that the scope can poke a hole out through the back of their pharynx, and you can rupture the diverticulum. Zenker's diverticulum is a loosening or over-relaxation of the posterior pharyngeal constrictor muscles. This often happens as a normal part of the aging process and is most common in elderly patients who present with a very slowly progressing dysphagia as well as regurgitation of undigested food products and halitosis. The diagnosis is with barium studies, nasogastric tubes, and endoscopy should be avoided for fear of perforation of the diverticulum. Zenker's diverticulum is never an emergency, and the only significant therapy is surgical resection of the posterior pharyngeal constrictor muscles. Surgery is generally effective, and as long as the patient is not harmed with the passage of a nasogastric tube, Zenker's diverticulum is simply a cause of odynophagia and dysphagia that can be easily treated with surgery. Therefore, resect it, remove it. Now, what we presented here is that with dysphagia, there is something a little bit different about each one of these diseases. Now, if it really was like this in life, why, we'd never have to do a diagnostic test, right? We would just go, well, you have that and you have this. Now, there's a difference between life and the boards. And the difference is, in life, anything can be anything. But on the boards, if they want you to answer, Which of the following is the most likely diagnosis? They have to tell you. A younger non-smoker with both dysphagia for solids and liquids at the same time. They have to tell you it's a guy with scleroderma with just the burning reflux symptoms. They have to tell you it's intermittent pain or intermittent dysphagia. They got to tell you something if they want you to answer that diagnosis. However, what we have done here is tried to give you something a little distinct about each one of them separate from the others. Don't start with manometry patterns. You'll herniate your brain. It will be painful to you and you don't learn it anyway. Manometry patterns is the least important thing. Knowing when to get manometry is important. I need to get manometry for spastic disorders. I need to get manometry when I have a pressure disorder in my lower esophagus. Knowing when to get endoscopy is important. Knowing the precise patterns is not as important. Now, the other part of this is, why is Mallory Weiss not on this list? Why is Mallory Weiss not here? We could fit a little Mallory Weiss here. Oh, wait, Mallory, oh, there doesn't seem to be room. Where's our Mallory Weiss? Mallory Weiss does not, I tried to fit it in, but look, I can't. Mallory, no matter where, somehow or another, Mallory Weiss just doesn't seem to fit in here. Did you notice that? Why does Mallory Weiss not fit in here? Mallory Weiss tear is an esophageal disorder. Mallory Weiss tear is associated with vomiting. How come it's not here? Because Mallory Weiss syndrome is not a cause of dysphagia. Mallory Weiss syndrome is not a cause of dysphagia. So since Mallory Weiss syndrome is not a cause of dysphagia, it doesn't go here. Mallory Weiss syndrome is the proper name applied to a non-transmural tear of the lower esophageal sphincter. Mallory Weiss tear is associated with progressive vomiting and retching of any etiology because of high pressure. It is not transmural. A transmural tear would be known as Boerhaave syndrome. Transmural tear or Boerhaave syndrome results in the passage of fluid and food particles into the pleural space. Mallory Weiss is a cause of GI bleeding, upper gastrointestinal tract bleeding, but it is not a cause of dysphagia. Mallory Weiss does not provide an obstruction to the passage of food or liquids into the esophagus. There is no particular treatment for Mallory Weiss. It is just someone who comes in vomiting for any reason. Any reason. Ready? Mallory Weiss. Mallory Weiss. See? Vomiting for any reason. Like hemoptysis. The pressure causes the bleeding. Hemoptysis, coughing up blood. Hemoptysis. Hemoptysis. Mallory Weiss. Whether it's hemoptysis or Mallory Weiss, any cause of coughing causes hemoptysis. Bronchitis most common. Any cause of vomiting causes Mallory Weiss. Hemoptysis, Mallory Weiss. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. Mallory Weiss syndrome presents as a cause of upper gastrointestinal bleeding, vomiting red blood, or black stools. The treatment is, in most cases, watchful waiting. It stops on its own. A small number of patients must have their upper esophageal sphincter injected with epinephrine or sclerosed if the bleeding is prominent. But Mallory Weiss is best described with causes of upper gastroesophageal bleeding. I will see you in the next tape. Until then, remember that the predominant thing about studying for Step 2 is not intelligence. It is endurance. Aristotle says the chief or greatest part of courage is endurance. Most of courage is endurance. He who perseveres and persists will win.